Good afternoon and welcome to the fifth and final session of the Nurse Staffing Task Force Project Echo Series. Session 5 is titled Achieving Excellence in Healthcare, Nurse Staffing Standards, and will be presented by Dr. Sherry Perkins, Dr. Matthew McHugh, and Dr. Nancy Blake. Just a few reminders before we start. Please keep your microphones muted to avoid distractions and any background noise. You can utilize the chat function to ask questions during the presentation and during the interactive Q&A. If you have any technical difficulties, you can tag at ANA admin for assistance. And lastly, we encourage your participation to make this an engaging session. Throughout the series, we have heard from members of the Nurse Staffing Task Force as they shared recommendations and actions to tackle the nurse staffing crisis. My name is Nicole Anselm, and I will be your host one last time. I'm a senior policy advisor within nursing programs at the American Nurses Association. Each week, the sessions of the series centered around one of the 5 task force imperatives, which brings us to our final imperative: establish staffing standards that ensure quality care. And I'd like to introduce our speakers for today. Dr. Sherry Perkins is president of Luminis Health and Arundel Medical Center and chief of hospital integration at Luminis Health, which is one of the busiest hospitals in Maryland, with excellence in behavioral health, cancer, emergency, obstetrics, orthopedics, and surgical specialties. She oversees business operations at the Systems Medical Center, the Behavioral Health Facility, as well as the Alcohol and Substance Abuse Facility. Dr. Perkins served as Chief Nursing Officer and Chief Operating Officer for Luminis Health and Arundel Medical Center from 2006 until 2016, and led the system to the top to achieve top results in magnet recognition. Dr. Matthew McHugh is a professor, and I would just like to remind everyone to please mute your microphones. Thank you. Dr. Matthew McHugh is a professor and Independence Chair for Nursing at the University of Pennsylvania School of Nursing and Senior Fellow at the Leonard Davis Institute of Health Economics at University of Penn. Dr. McHugh is the director of the Center for Health Outcomes and Policy Research at Penn Nursing, where he conducts highly visible studies that draw on his expertise in nursing, law, public health, and health services research to evaluate how nursing can be a force for quality, equity, and innovation in health services. A fundamental goal of Dr. McHugh's program of research is to bring evidence to bear upon the health system, law, and policy reforms needed to facilitate effective nursing practice and achieve the best patient outcomes, health equity, clinician well-being, and important national and international health policy goals. He is an elected member of the National Academy of Medicine, fellow in the as well as fellow in the American Academy of Nursing. And lastly, Dr. Nancy Blake is the Chief Nursing Officer at Los Angeles General Medical Center. She was the Chief Nursing Officer at Harbor UCLA Medical Center from March 2019 until June 2021. Prior to that, she was Director of Critical Care Services at Children's Hospital of Los Angeles for over 30 years, where she helped the facility achieve magnet designation. Dr. Blake has been an active member of ANA, SPN, ACNL, AONL, and AACN, where she was a national board member from 2003 to 2006. She's a national speaker on pediatric disaster preparedness, staffing, and healthy work environments. Dr. Blake has numerous publications on healthy work environments in healthcare, and she is an associate adjunct professor at UCLA School of Nursing and was named the Distinguished Alumni Member for 2021. So today's session, we will be focusing on describing the evidence base for establishing staffing standards, identifying ways that nurses can advocate for the adoption of enforceable policies that support staffing standards, and discussing strategies for implementation that nurses can employ in their own work environment. And with that, we're going to jump right into our presentation because we do have a lot to cover today. So I turn the floor over to Dr. Perkins.
Thank you, Nicole. And it's a delight to be here today. I want to say an important thank you to all members of the task force and to the ANA. I was very honored to serve as co-chair of this task force. Thanks to Nicole for hosting, and to my co-presenters, Matt and Nancy, and Katie Boston-Leary, and I also saw Sarah Delgado, many of our colleagues from the task force who contributed this so much. But mostly, I can see our numbers are almost up to 300, thanks to all of you for this nearly 300 folks who've joined us today. So just to warm up a little bit here, throw into the chat when you first remember learning about staffing challenges in the United States. Just take a stab at this. Yeah, so I'm curious what kind of dates we're going to see. So we've got, I see a big range. I think the earliest one I saw was 72, 74, 94. So we've all got an experience with this. Keep it coming. All right. When I first started nursing school, there's a lot. And the main point of this question is it didn't just start yesterday. I just pulled this one. I think Matt and Nancy, scholars on this topic, would say we could take this back to Nightingale. But regardless, we know this didn't just start. So my next question to you, and you can launch the poll, is how much do you know about the task force recommendations already? So if you do us a favor and answer the poll about your awareness of the National Nurse Staffing Task Force recommendations. My job in this presentation is to just set the table with regard to our basics on the recommendation. The real food on this table will come from Matt and Nancy. And the idea, as Nicole said, is we're seeking to drive action, not have a set of material sit on a shelf. That's the whole point. So we hope that you'll hear action-oriented discussion. How are we doing on the poll, Nicole?
We have about 180 responses.
All right, let's just see what we've got. So we've got, this is important. We've got a good percentage that have, can you pull the poll results back up for me? A good percentage not aware, and a bit somewhat aware, but a very small percentage known by heart. And so what we're going to encourage you to do is go back to the earlier presentations, understand the work that has happened since 22. Well, this is, as demonstrated by your feedback, has been a topic for many of us for decades. We have had significant work in this space at the national level in what was called the think tank and now the task force. And again, we want action on this. Next slide. So please be sure to go back and grab this material, understand the recommendations from the think tank, and understand the recommendations from the task force, which has been the focus of this series. Next slide. So from the task force specifically, the work, thank you, Sarah, for popping that link in. The recommendations that have come from the task force range from reforming the work environment. We want a physical and psychologically safe work environment. We want to better value the contributions of nurses. Want to innovate models for care delivery, improve regulatory efficiency, and the focus for today, establish staffing standards that ensure quality care. And that's brings us again to the meat for today. So what's important for you all to know at the outset of the task force, so while we yielded 5 recommendations at the outset of the task force, a major initial effort was a definition of appropriate nurse staffing. So our definition of appropriate nurse staffing involves these key phrases. It is a dynamic process that aligns, and very importantly, the number of nurses, their workload, their expertise and resources with the patient needs. And that these of course, these attributes lead us to quality outcomes within the healthy work environment. I'm going to emphasize here that there are important components that we don't want to get lost in this. Number of nurses matters, expertise matters, and other resources matters. So it's not one of those elements, and that all of those elements have to be managed with nursing expertise at the table to drive to get to appropriate staffing. Our objective here out of this work is to drive action every shift, every unit, around the clock, every day in our hospitals, and also lead in a national way on this. And here is how we have said that we'll get to that action. We have 4 specific actions. Next slide. So the first one speaks to specialty nursing organizations, that we believe a major effort is to ensure that we've developed specialty standards and that you know your areas and that you're seeking to act on those areas and giving a voice to act on the staffing recommendations coming from specialty organizations. The second one relates to pathways that exist with regard to regulation and legislation that advance minimum staffing standards. A critical point to emphasize here is there are many pathways to this that allow us to think about regulation and legislation. The third item relates to CMS policies that support minimum staffing standards. So you can see how these all begin to build. We have specialty nurse organization staffing standards, pathways such as regulation and legislation, and then CMS policies. And one that we've been particularly excited about is recognizing that the Joint Commission pays a lot of attention to patient safety, and that we can work with the Joint Commission to speak to standards to support appropriate staffing. So another question I would ask you all to think about as you consider whatever role you're in, rate your ability to consistently address staffing in a meaningful way. So let's think about this. When you consider whatever role you're in and meeting that definition of appropriate nurse staffing, how consistently can you address it in a meaningful way? Let's see the poll result. So we have a solid 36% in the good, and a bit north of that in very good or excellent. But again, about 40% as this impact being poor or very poor. We, again, want to drive action that allows you to answer this question consistently as excellent. All in with this. I, as in the introduction, service president of a 400-bed magnet-designated hospital, and we've spoken about nurse staffing my entire career. And what I want to emphasize to everyone in this group is that your board members and your C-suite, your executives, your CNOs, your CFOs, everyone at the table need to, and you should expect them to pull all levers for adequate number and competency of nurses. you should expect this. There are many, many things that we can agree on, that adequacy of nurses, the numbers and their teammates are essential to care, that nurses stay in hospitals because of quality and patient experience in a healthy work environment. And some standards are adhered to in some settings, but not in all cases. And there are barriers to staffing, financial measures, productivity measures, and we know there are implications of this. But we as hospital executives pay attention to a lot of things, and we should be expected to drive action on this topic. So I'm going to hand off now to Dr. Matt McHugh to discuss the evidence that drives us to this action. Thank you very much.
Thanks, Sherry. And I'm just making sure I've got control here. So just a little orientation to what I'll talk about. I'm going to focus principally as a policy intervention on minimum nurse-patient ratios as a policy intervention. As Sherry said, that's just one arrow in the quiver potentially, and you know, in the ways that it's been implemented so far is only a kind of very limited way of even thinking about that particular policy, and something I'll talk about in terms of policy innovation toward the end of what I'll present. I'm going to start by just kind of getting at empirically, is there evidence that we even need policy intervention? Why do we think that this should matter and get the interest of policymakers more broadly? This is a result of a study that we did in 2 states representing the hospitals in those states. And what we found right before COVID, this was in December of 2019, on average in medical surgical units in general acute care hospitals, across hospitals, the average med-surg nurse could be taking care of anywhere between 3.5 in some hospitals all the way up to 10 patients per nurse. So what we have is significant variation that is not accounted for by the variation in acuity within those units. And this is just another way to show this kind of variation. This is data that we have from 4 states in the US, and it's hard to tell, but each of these little kind of ridges represents a bar that is one of 600 hospitals. And you can see this was back in 2006, ranging again from about 3 to 12 patients per nurse on average, which, at least to me, on its face, is an unacceptable level of variation in your average med-surg environment that, you know, simply is implausible to be accounted for by the acuity. And so, you know, a very strong literature base around the evidence for a relationship between nurse staffing levels and really every outcome that's ever been looked at in terms of patient outcomes, including things like mortality and readmissions and hospital-acquired conditions, also patient satisfaction. But, you know, obviously of high of mind right now, especially are nurse job outcomes like burnout and clinician well-being. We'll talk a little bit about some of this. Sorry, I'm delaying because it's taking me a few clicks to get the slides to move. All right, so just a little context for nurse staffing policy. I think most of us are probably aware that California is the first, not the only now. Oregon has joined California, but the first state to pass a comprehensive acute care policy that established minimum nurse-to-patient ratios. It took a while for it to roll out, but it has been in place now for a few decades. There are other jurisdictions, Massachusetts has ICU based staffing limits. There are some Medicare rules also in place. There's a lot of international interest. And as I said, Oregon, they have not implemented yet, but I believe are on the path for 2024 to implement legislation that has now passed. So, this is a policy intervention that has been in the discussion for a long period of time. There are different ways to implement it, and it has grown in interest in the past, especially 5 years. So just to talk a little bit about what we know about California. So, the first order question, in order to get any benefit from a policy aimed at improving staffing to yield better patient or nurse outcomes, we have to first test whether staffing actually improved. And so this is data from a study that we did published about 2 years ago, looking at nursing hours per patient day across 4 states. We also did this nationally, but as you can see, a pretty clear separation between California and the 3 other states that we were focused on at the time. We published this work in Health Affairs. We revisited it in looking at the effect of the Great Recession, which, there are some interesting phenomena happening there. We know whenever there's financial pressures on hospitals, it can result in cuts to labor. It seems to have flattened in California post or through the recession, but has continued to grow since then. And importantly, one of the concerns about these kinds of policies is, well, staffing may, if hospitals have staffing levels that are better than the ratios, maybe they'll reduce staffing and it will have a negative impact. But what we see is there's no such kind of capping in California that's occurred, and this has been in place since 2004. So largely that's at least not an empirically supported concern. So the question about patient outcomes is a little muddier, but there are some important takeaways. So just to give an example, we've done a estimation of what the effect of staffing would be in Pennsylvania and New Jersey, 2 states without similar policy, if they were to staff up to California's standards, and we show a very clear relationship with patient mortality. But importantly, we kind of missed the boat as a research community on California because no one was able to really go in and collect very good data on staffing consistently in the baseline before the California policy was 1, passed, and 2, implemented. So, we've done some, design tricks that researchers can do in order to try to understand the effect. But there are also a lot of compromises along the way, and that kind of muddiness has resulted in a lot of stakeholder debate and contention around whether ratios worked or not. But important to note that, to the degree that there is information on patient outcomes, it's largely that it has either benefited or at least not caused negative outcomes. But there are a whole lot of outcomes that have never been studied. So I'm going to take just a little bit of a different tact and actually talk a little bit about what is the evidence for the arguments that are often posed against staffing standards as opposed to kind of the for staffing standards. And I'll take just one example that kind of encapsulates the kind of arguments that often come up. So this is an advertorial, I think is what it's called, the American Hospital Association. And there was a paragraph in there that I thought was useful, and we can kind of pick this apart. And so they say, meanwhile, some suggest there should be rigid nurse-to-patient ratios. We strongly believe nurses need to be empowered with flexibility to determine staffing needs. One size fits all isn't appropriate, and there's a workforce shortage. So I'm just going to take a couple of those lines. So importantly, the with the statement about who is suggesting there should be nurse to patient ratios, it's important to note that this is in our research of hundreds of thousands of nurses. This is the number one thing that nurses say that they need, not necessarily a particular California policy or the, Queensland policy, but some sort of intervention is needed. And what we're finding in our work with physicians is physicians are rating nurse staffing as a higher priority for their own well-being. And part of what we've shown is when you look at those two things independently in the same hospital, if you look at physician burnout levels, the levels of nurse staffing independently predict the odds of physicians being burned out, which is an interesting phenomenon, points to the kind of system level effect that inadequate staffing and resources can have. So the next line is we need nurses to be empowered with flexibility to determine appropriate staffing. Yes, I think everyone would agree with that, but I think it's important to interrogate a little bit about how nurses or how much nurses are empowered now in the status quo, in the absence of having some policy support. And so what we find is in the literature, one of the ways that it's discussed is having staffing committees. Now, staffing committees, I don't have anything against staffing committees, and I think that they can be a positive thing, but it's important to note that empirically, they don't actually appear to be changing staffing levels. So they may be valuable for governance and involvement, but it doesn't seem to actually change. When we survey nurses, they report very little control over their own assignments in terms of the number of patients that they're cared for, maybe a little bit on which types of patients, depending on skill and experience. And then when we talk to managers, they largely say, they're constrained by the budget. If it's in the budget, then they can do it. And so there is some flexibility and discretion there, but in the US healthcare system, we know about the issues about, nursing being largely invisible as a revenue line. And so often in the US, whenever there's financial pressure, the kind of go-to strategy is to cut labor, and in a hospital, that's largely nursing. A one-size-fits-all or one-size approach doesn't fit all. And it's important to note that's never been part of any of the policy in terms of the actual policy. It is something that is constantly raised, but I'll just point out one of the kind of prototypical bills is in California on the right-hand side. I've just pulled this directly from the bill, and it says these ratios shall constitute the minimum number of registered and licensed nurses. And then they go into a whole list of things that should also be considered and accounted for in the decisions around staffing. So the minimum is really, in all of these policies that I've raised, is really just about setting kind of a floor, a starting point for safety. But the expectation is that all of the local differences across hospitals should be taken into consideration when making staffing decisions. There isn't a reduction in the ability to do that, and it isn't specifying that every nurse has to take care of a particular number, but it does set a minimum for a maximum of patients. And last, the workforce shortage crisis, and this is something around that I think is important to note, because shortage can mean a number of different things. In the US, empirically, we do not have a supply problem in terms of the low production of nurses. In the last 10 years, we've produced as many nurses as the 3 decades prior combined. And nursing schools have been producing new graduates at rates that far exceed what was expected. And essentially, since the year 2000, we're up to from 71,000 nurses, new US first-time NCLEX takers, 71,000 all the way up to 188,000. So, I mean, that's great. So we're producing new grads, but that doesn't mean that there's not a shortage at the bedside. But it is important to distinguish those two issues if we want to have a solution to the problem. And if we want to use this as an argument against implementing ratios, what's important to note is California actually has the lowest, depending on the year, the lowest or the next to lowest nurses per capita in all of the US, yet they have the best staffing. So the actual supply of nurses and the supply of nurses in a hospital or at the bedside are not a one-to-one ratio, and they can actually go in opposite directions. Another concern, safety net and critical access hospitals. I think it's a reasonable concern. I think we need to be thoughtful about implementing smart policy to make sure that there aren't unintended consequences. But largely in California, we saw no evidence that there were significant closures outpacing what we would see in other states. And actually safety net hospitals and critical access hospitals saw the greatest improvements in staffing following the implementation. And then finally, inhibiting innovation. And this is an important thing. I think that it's important to understand. I mean, really, innovation is kind of at its base a neutral thing, and it all depends on kind of how it's being implemented. Certainly, we can all think about this related to the EHR. Sometimes it can be helpful. Sometimes it's a pain. Sometimes it's a bunch of added work that doesn't help anyone. And so it's important to think about, well, what are we saying are the alternatives to having additional nurses? And some of the examples that come up are ideas around team nursing. And I think it's important to ask whenever someone raises this, what do they mean by it? There's certainly evidence that our past experience, how it's been implemented, was associated with worse outcomes. We definitely know lower skill mix is linked with worse outcomes. And then there's been discussion of interdisciplinary providers. And I'm never myself, at least, quite sure who that is, because obviously folks like social workers and respiratory techs, they've got their own jobs to do. And I know family members have come up, which I have my own issues with. And then there are things that are really untested: virtual nurses, robots, artificial intelligence, and they may be great and good as supplementing or offsetting some of the work. But I think as a profession, our goal should be to be evidence-based, and if we can demonstrate that there's a value here, yes, then implement, but not offset. And so the last thing that I'll focus on is just to highlight that ratios is not a policy. There are a lot of details in all of the different policy proposals across jurisdiction. There is no one way to implement these policies. And I would argue that we've really lacked imagination about what should go or could go into a policy to address some of the legitimate concerns that folks may have, while still establishing minimum safety standards around the core business of what it means to be a hospital, and that's deliver bedside nursing care to patients who need it. Just one example where I think we have had the advantage of being able to study a policy with pre and post implementation data in Queensland, Australia, where we had a comparison group, a control group, and an implementation group. We were able to study the policy that they implemented, which was slightly different than California in that the ratio was applied at the unit level. So I might, on a med-surg, be assigned 7 patients, someone else might be assigned 2 patients, and the average, as long as the average was within the specified limit, then that was compliant, as opposed to the California model, which was I couldn't have more than 5 patients, my coworker couldn't have more than 5 patients, et cetera, which, arguably, does increase some of the constraints on managers to be able to be flexible throughout the day. What we found is that the benefits in Queensland were definitely associated with the significant increases we saw in the treatment hospitals, the hospitals where the policy was applied. Essentially, all of the nurse reported outcomes and nurse job outcomes like burnout and job satisfaction were less and were attributed to the staffing increases that we saw in the treatment hospitals. And then similarly, we saw benefits to the public. We saw mortality reductions, readmission reductions, and a really significant reduction in hospital days, hospital length of stay. At least the two readmissions and hospital days, you could attribute some financial numbers to kind of estimate what are the costs that were avoided, given that this was implemented in the treatment hospitals relative to the control hospitals. And I'm happy to, well, I put the citation here. This is a Lancet paper. So I'm gonna pause there and hand off to my colleague, Dr. Blake.
Thank you, Matt. And so I'm gonna kind of switch gears a little bit, but a lot of what Matt and his colleagues have done in their research looking at a richer RN mix. You know, we know through the research that a richer RN mix, caring for patients that need that high acuity of the registered nurse had better outcomes. But what I'm going to talk about is, you know, my experience as a nursing administrator in California for the last 40 years, you know, dealing with the ratios, trying to make sure we stay within the ratios, but understanding that the ratios are at a minimum and they don't, they're not the magic wand to fix all the issues. So I'm going to share what I was able to do with my staff in a county facility. I currently work at LA General, but I worked at Harbor General, Harbor UCLA prior to working here during the pandemic. And I saw that the minimum ratios wasn't a one size all fits all or fix all the issues. And I think what's important is nurse staffing is a collaborative effort with leadership and their staff. And I've been lecturing about this for probably the last 10 years. And I hear what I consider sad stories from around the country where nurses feel like they're understaffed and there's no support from administration. But I know my administration supports to do what's best for the staff and the patients. So I'm going to talk about what we've done here and talk a little bit about some of the unintended consequences of the ratios and problems that the nurses really didn't like in California. So, you know, like I said, I'm going to share a California public hospital systems approach to developing policies together with the frontline nurses and leadership collaboration that not only got approved by me as a CNO at one facility, but all the CNOs at all 4 facilities, and then the CEOs as well at the 4 facilities. So we talked about the fact that I saw some staffing during the pandemic. I was relatively new to the hospital where there were 2 very critically ill patients, and the nurse was taking care of both of them, and realized that the staffing was set at minimum staffing ratios. But we needed to look at something else, some objective criteria, not subjective criteria, but objective criteria that we could agree on to really look at those patients that were greater than 12 hours of care or 1 to 2. And the ICU nurses were not a shy group. It was the trauma ICU. They approached me, and we're in the process of publishing this as well to discuss, you know, the types of patients they believed needed to be 24 hours of care or 1 to 1. And so they threw out some ideas, and I said, not really. I mean, the first idea they discussed was somebody on CRRT. And I said, but somebody who's stable on CRRT, once you set up the machine, you know, that nurse can easily take care of 2 patients in the ICU. And so I said, you know, I need more statements that discuss really the types of patients that are one-to-one in and of themselves, and then maybe one-to-one criteria because they've got other things going on. So we had several meetings and several negotiations where we went back and forth. It took us about 2 months to fine-tune the policy. And I'll talk about some of the examples that we put together. And everyone I've shown this document ever since it was developed has said, you know, that's really a good document and this really makes sense. We developed the one-to-one criteria, and then I brought them to the system CNOs in the 4 hospitals, and then brought feedback back to this committee. And then we finally agreed upon final criteria, and I brought them to the system CEOs in 2021. And it's become, it's not listed as a policy, but it's an expected practice, which is the same as a policy. So basically, this one-to-one proposal that they submitted, there were some guidelines, and that we would look at the patient acuity every 6 hours. And that would be the primary nurse and the charge nurse together to really see if that patient still needed the 24 hours of care one-to-one criteria. The patient's acuity, we looked at it. We had Avalysis at the time. Now we have Cerner Clairvia. And looked at the condition and see if the acuity level, because in the state of California, I'll talk about that in a minute, and Matt talked about it already, we need to not only have minimum ratios, but we need to have a classification system. So those are both required in the state of California. And so we have a classification system that we look at as well. And basically we staff by minimum ratios unless the classification system says otherwise. And so we talked about the different levels, and like I said, I'll give you some examples in the end. And then we made all efforts to provide one-to-one patient care as staffing permits. And I was able to work on the budget for the system in critical care a couple of years ago. And we figured out that about 20% of our patients were so acute, because I'm at a safety net hospital, 650 beds. We run about 500. Trauma center, STEMI center, stroke center. We have a jail ward, burn center. Our patients are pretty high acuity. And so we would look at it, and then, you know, if a patient met one-to-one guidelines, at the time, they'd notify the nurse manager or they'd notify the nurse supervisor. But when we implemented our Cerner Clairvia system last year, we actually built it in so the charge nurse can actually say this patient meets one-to-one criteria, even when the classification system hasn't given them 24 hours of care. And it puts a comment, and then they actually can do something in the system so that patient is a one-to-one patient. So here's some examples of a patient that is a one-to-one in and of it themselves. And one of those examples was, can you mute yourself? There's somebody who's coming across. Thank you. An organ donation patient. Sometimes those patients can be really busy because they're working them up for multiple different centers. They may be, you know, increasing the vent settings. They may be adding drips to keep their blood pressure at a certain rate. And sometimes there's 2 and 3 nurses in that room. Now that our local organ donor agency actually has a donation center, they sometimes take the patients out of the hospital to their donation center and complete their work up there and do the donation at their center. But those patients can be pretty busy when they're first working them up. Sometimes they're not, but sometimes they are. A post-op open heart surgery patient that's unstable for the first 6 hours, we may keep them as a one-to-one patient, and then we reevaluate. And at any point, we reevaluate. And an ECMO patient usually has a nurse at the ECMO pump and one taking care of the very critical patient. And all of the acuity systems don't trigger 24 hours or 48 hours of care, which is a 2-to-1. And so we can actually put that in the system and change our acuity. So those are just an example of a 4-page document that we have that this is a one-to-one patient in and of themselves. And then we developed a section 2, which they have to meet 2 criteria. So somebody who's hemodynamically unstable, and then they have other things that are going on. Maybe their vet settings, they're going up and down in their vet settings. They're on CRT, they're on a balloon pump. So we have a whole list of things that will trigger, you know, somebody being a one-to-one that are actually more than one criteria. And this has been a pretty good document. We evaluated it after we did it about 6 months later. We made some modifications, but for the most part, this was driven together with leadership and staff, which I think gives it much more credibility when we talked about it, and really make sure that our patients get the care that they need and our staffing is good. Do we have perfect staffing? No, we don't. I don't think anybody does, because sometimes you can get last-minute sick calls, and no matter how well you prepare, you still may fall short. But we are doing everything we can, and in the state of California, we have to show the state that when we were out of ratio or we weren't staffing to acuity of the patient, we did everything we could to call people in. With our new system, it allows us to text out to those that want to work overtime, the ability to come in and work 4, 6, 8, 12 hours to come in and help fill the void. But I think the importance of this was that we work together with the frontline staff. And I think that's what this is all about as we move forward. Making sure nurses can work at top of license, make sure that they have the support staff that they need, but make sure that they feel comfortable with our system, our acuity system and the patient classification system. And Matt talked about a staffing committee. We're required to at least once a year do a validity reliability study on our acuity system and make sure that it is reliable and that it is actually measuring what the patient actually needs. With our new system, which we call Aster, but it's a Cerner Clairvia system, which I understand Epic has done the same thing. And it really drives from the medical record and does nursing outcome classification and puts people in an illness to wellness continuum. And those that are very ill will be not hitting their triggers for cardiac, respiratory, and it drives more hours of care. And so that's how that works. But we also are validating. So we have a staff nurse twice a month do a check by hand of the system and what the patient should end up. And then they look at what the system has developed. And I'm here to say that Cerner has said they've never seen such good reliability of the system. We're at about a 98% that the system is actually generating what the nurse believes as well. So we're very excited, and we just rolled it out to the rest of the house. And for the first 2 months, or the first month, we actually have similar reliability in the system. So twice a month, we have nurses do, kind of a handheld, and that's what we show both to our union partners and to the state that the system is reliable. But like I said, we also simultaneously reevaluated the budget, and it showed that about 20% of our patients were ending up 24 hours of care. So we had to add staff. And in a county system, you go through DHS and then you go down to the county CEO's office. So it's a little bit more cumbersome, and show that we needed a few more staff to be able to staff these patients, because you can't do it with minimum staffing ratios. You can't all of a sudden make somebody a one-to-one without closing beds or, dealing with other issues. We also needed a break nurse, somebody who comes in because by labor law, they have to get 2 15-minute and a 30-minute break and 8-hour shifts. And most of our staff are on 12, so they get an additional 15-minute break. We have to make sure people get out on their breaks. And I think that's important for a healthy work environment as well, because people need to step away. And then we need to make sure a charge nurse is free from patient assignment as much as possible. And now more than ever that's really important, because we are dealing with a lot of new grads. And it's very different to have 7 nurses that are experienced and maybe 4 nurses that are experienced and 3 new grads. The new grads need more help. So to have a charge nurse that's free from patient assignment is really important to us as well. And then reviewing the span of control for managers and assistant managers, and not having a manager have 100 staff, and because it's too much to handle. And I think even more post-pandemic, looking at the healthy work environment surveys, some of the work that was done by the Jocelyn Insights Group, to look at nurse burnout, it's really important that we have support for our new grads, and that we keep our staff. And Matt said, we have the lowest number of nurses, yet we have ratios. And California is a hard place to live, so a lot of people are moving out. But just because we have a rich mix and ratios doesn't mean we have the highest number of nurses staying in California. So some of the unintended consequences of the ratios, and I had the opportunity, the person by the name of Kathleen Billingsley was the one that developed the ratios. And just some history, and Matt kind of touched on this. In 1999, the ratios were voted on by our legislatures. And so they asked California Department of Health to develop the ratios. So they didn't develop these ratios. These were developed by the Department of Health. It said that there should be no more than 50% are LVNs, or LPNs, they call them in other areas, or in the psych area, psych techs. And then in 2004, they took effect, and they were modified in 2008. But here's the ratios as they are in California. In 2008, the step-down telemetry and med-surg changed their numbers just a bit. And then the other thing that's really difficult is in ED, it's 1 to 4. And I used to work at Children's Hospital, and when you had 4 patients with diaper rashes, it didn't make any sense to have a 1 to 4 ratio. But it is trauma. It should be 1 to 1. Critical care as sick trauma. Sick critical care patients should be 1 to 2 in the emergency department, and all others are 1 to 4. And then labor and delivery, they're 1 to 2 as well. So the one thing that the nurses really hated was the at all times piece. Nurses used to go on break together. They used to do all their work and say, you don't need to do anything, just watch my patient. And that was no longer something that we could do, because if you needed a 1 to 2 ratio, it used to be that 1 nurse would watch 4 patients. We couldn't do that anymore. So the state of California, the person, Kathleen Billingsley, who actually did develop the ratios, asked if she could come to a hospital, and nobody took her up on it. But finally, my boss, my CNO at Children's Hospital Los Angeles, said, come on down. And she sat with nurses who said, we really struggle with this at all times piece. We like to finish our work and not have somebody do a lot of tasks while we're gone. And the new staffing process required someone be available for breaks. So you'd keep at that all times, or else you started, with more than 1 to 2 as the minimum ratio in the ICU. But when somebody went on break, nobody could take more than 2 patients. So that was something that they didn't like. And then the nurses asked her, how did you develop these ratios? They were just curious. And she said they did time and motion studies, and they followed nurses around. And her research assistants, which I thought was interesting, were primarily medical students. So they had no idea what nurses did. I've been an ICU nurse in the past, and somebody would be extubated, and you're not sure if they're going to need to be intubated. There would be a nurse watching them at the bedside. In the study, they got no credit for doing anything. The nurse was not doing any nursing work. So the fact that we were standing in the room, assessing from the doorway, none of that was included when the ratios were developed. And so while the nurses liked the fact that they had more staff, and they liked the concept of ratios, and having more licensed nurses, they didn't like the at all times piece. And they didn't feel like it was the be all end all, saving point for nursing. And as I shared with the 1-to-1 criteria, if we were to staff by minimum ratios, some of these patients wouldn't get the care that they need. So we staff by acuity, except when they fall below the ratios. So, it was really nice that I could understand, we could meet with this woman. And I have to say, she felt kind of bad, when the nurses, because some of the nurses were pretty adamant about some of the things that were in the law that they didn't like. So additional requirement in state of California, you have to have a classification system. And basically we also need to determine the individual patient need. And Matt already talked about this from the registered nurses assessment. And that's where we developed the 1-to-1 criteria, that if the classification system didn't make them a 1-to-1 and they needed to be, the nurse can. And if we ask that the charge nurse together with the bedside nurse work together on that. And then that we have to have a reliable and valid tool, and that we need to check the reliability and validity annually with the tool. And that this group that actually looks at the data and works on this committee need to be 50% staff nurses. I do say that with the new system that we developed, the fact that we're doing 2 a month, we have a lot of buy-in from the staff and a lot of engagement to actually do that validation of the system. And it's very exciting because it's continued for a year, because we rolled it out in the critical care area first. So I think trying to tie everything that we've talked about to the think tank recommendations based on today's discussion, we really do need to empower professional governance committees and nurses, with direct care nurses, the authority to create and sustain flexible staffing approaches. We need to advocate for some type of minimum staffing standard. And I know ratio in some people's vocabulary is a bad word, but I think everyone has some kind of grid that's a numerical value. And I think that that was something that the think tank recommended, that you have to have a minimum staffing standard. And then we have to advocate for development and utilization of approaches that quantify nursing's impact on organizational performance and outcomes. And I saw a lot of people talking about NDNQI and Magnet. We're on the Magnet journey, but our numbers look pretty good. And as staffing got better post-pandemic and nurses, we started hiring more nurses because we had a lot retire in the last couple of years. Our numbers got better, and that's happening across the country. I just came back from the Magnet conference. So now we're gonna switch over to the question and answer session, and I'm gonna introduce the questions, and then I'll turn it over to Nicole as she discusses how we're gonna do the breakouts. So the discussion questions, there's 3 different sections. Pick one of the 3 existing policy interventions currently used at the state level for promoting staffing standards. And we talked about public reporting, required committees, mandated ratios. How is this policy effective? What are the unintended consequences of this policy? How could we build a more effective policy? In one of our task force discussions, some of the members felt that the imperative establishing staffing standards conflicted with the imperative to innovate care delivery. How do you see these 2 imperatives interacting? And the third is, what are the actionable steps nurse leaders and hospital executives can do to advance and implement these recommendations forward at the individual level, the institutional level or unit level, and the policy level with associations? So I'll turn it over to you, Nicole, to explain how this is going to work.
Okay, so in just a few minutes, we will all be divided into breakout rooms, and the breakout rooms will not be recorded. So please feel free to speak amongst your peers and really engage with each other to see what's working for other people, what's not working for them, and why, if you can identify why it's not working. So while we wait for that, let's take a few questions from the chat.
Sure, Nicole, and I can take it from here. Hello,
Thank you.
everyone, and thank you, Mr. McHugh, Drs. Perkins and Blake for that informative presentation. Thank you to our attendees for your engagement in the chat. There's been some interesting discussions and the sharing of some very helpful resources. Before I jump into some of the questions that I noted in the chat, is there anyone who would like to go off of mute to ask your question? Okay, if you change your mind, don't hesitate to use the raise your hand feature. I will go ahead and start with the question from Cornelia Gilpin. This was asked earlier on the presentation, and she wanted to know, has there been or is there any patient outcomes and nurse satisfaction data with mandated ratios?
I'm happy to take that one on the. So let me just make sure I understand the question. The question is evidence for both nurse and patient outcomes, benefits or lack thereof relative to nurse to patient ratio. I'm going to assume policies. And there's a 1,000 papers just demonstrating a very clear relationship. Better staffing is associated with better both nurse and patient outcomes of virtually every kind of outcome that one could look at. On the policy side, as I mentioned, the California kind of ability to study has a lot of challenges to it. There's been very little that's looked at the effect on nurses. We're actually doing just a simple comparison over time at the changes in nurse burnout in California relative to 4 other states that we have data over time on. Very clear that the rates of burnout are much lower in California and have actually, especially post or kind of during the pandemic up until now, the gap has grown. And so, burnout pretty much increased everywhere, but was lower to begin with in California and has not recovered outside of it. But it's not to say that, as Nancy said, that California is perfect. On the patient outcome side, as I said, the outcomes data is largely pointing to, depending on the outcome, either benefit or lack of harm. There are, again, in some ways depends on the quality of the data that one has. And one of the challenges with California is the ability to compare to something. So researchers have been kind of forced to look within California, but all the hospitals were exposed to the same policy at the same time. So it is a little bit a difficult thing to answer. One of the things that we're embarking on now, given that Oregon has recently passed this policy, we are doing both baseline data collection and follow-up data collection in Oregon and a set of comparison states. So hopefully we'll have a much more definitive US answer. As I said, probably the best study that includes pre-post data and comparison on both nurse and patient outcomes is the Queensland policy that we published in Lancet, and a very clear, at least on 3 of the 3 patient outcomes that we chose, which were mortality, readmissions, length of stay, and then burnout, job satisfaction, intent to leave in those hospitals.
Thank you. Thank you, Matthew. We do have a question from Sean Mitchell. Please feel free to take yourself off of mute and jump in.
Thank you. My question pertains to virtual nursing and how virtual nursing is being included in the mix. And I don't know that we have really been able to define what the parameters need to be. And the little short studies that I have seen on it say that it's, you know, the be all end all and it brings nurses back to the fold and the family's happy and the patients are happy. And I just would like to see how, I would like input into how people see that that is going to impact our staffing ratios and if that long-term satisfaction that everybody is reporting, at least in the short-term studies I've seen, that if that's for real, because I'm incredulous.
I can take that one. I don't have the exact answer you're looking for, but I think, you know, from just coming back from the Academy meeting and the Magnet conference, I think people are using virtual nursing interchangeably. So some of it is assisting with activities. I know I'm doing, we have virtual discharge through one of our AverShare machines, which we used for telesitting. We actually have nurses in our discharge lounge doing discharge teaching to our patients that can't go down to the discharge lounge because they can't get out of their bed or they have an infection issue. And I'm going to introduce, based on feedback from my staff, having some of the additional paperwork on admission to be done by virtual nurse as well. California has not weighed in on whether you can use any of those virtual nursing options in your staffing ratio. So I don't believe that we'll be able to use any of that in staffing ratio. Some hospitals are using them to support the new grad. So they're actually that double check and additional person. But I don't think there's any answer nor any detailed research on virtual nursing at this point in time. So, you know, that's what I've known because I've looked to see what it is. I know the state of California has some grants to do some creative things. And I was going to approach my union partners to say, hey, do you want to look at potentially doing something that will help support the nurses and start talking about what is it that we can do that's different, that's innovative, that also gives us the staff that we need and gives the patient the care that they deserve or that they need based on their acuity. So that's what I know. I don't know that any of us have your answer to your question, though.
I was just curious if there have been any financial inputs, either from CMS or from the states, regarding paying for virtual nursing.
No, I can tell you no. And, you know, they're already, you know, trying to pull back from their virtual visits that they agreed to pay for during the pandemic. So, you know, I'm not sure CMS is going to weigh in and offer any money on the table right now with hospital finances the way they are.
Thank you, Sean. Thank you, Dr. Blake. Let's see, a couple of other questions here. One from Catherine Riemann. It looks like a 4-to-1 ratio in one hospital may look very different than a 4-to-1 ratio in another hospital. How do we account for this variability?
Well, I can take that. You know, we've had some travelers in our organization, you know, through the pandemic. And they talk about working at small community hospitals, you know, in smaller communities and how the acuity is so much higher because we have, you know, we have homeless population. We have patients that have both psychological and medical issues. And like I said, we're a very busy trauma, stroke, and STEMI center. And so I think depending on the type of facility, you know, the ratios, if you just blanket have the ratios, it may not be enough in some of those high acuity hospitals.
Thank you, Dr. Blake. We have just a few more questions here. One is, do we know if there are any staffing ratios for nurse case managers?
No, and somebody just
Don't
asked
know
a question
of any.
about support staff as well. And while we have a number that we're looking at reevaluating, there are no, in the state of California, I can speak to, there are no minimum ratios for support staff. But we're trying to bring in more support staff, more phlebotomists. I mean, really allowing the nurses to work at top of license. And I think that that's the key to our new staffing models is to make sure. I mean, I started in 1980 when we had team nursing. Do I want to go back to that? Absolutely not. Were there some good things from that and some not so good things from that? Absolutely. But I think we really need to look at phlebotomists, so nurses aren't doing all the phlebotomy and all the EKGs, and making sure we have the appropriate support staff so nurses can do what they need to do and work at the top of license.
Thank you, Dr. Blake. We have one final question here that I purposely saved for last. Will the RN shortage ever be solved?
I'll be happy to. I mean, history says no, but I think again it is absolutely important to define what we're talking about when we say that there's a shortage, because as I pointed out, you know, because that has implications for what are the potential solutions. There have been many times in the US where we have had a production problem. We did not, you know, from a university or hospital, school of nursing or diploma programs, there was just simply not enough new nurses being produced to meet care demands or even, you know, potentially work in positions. That is not the issue that we have now. But again, that doesn't mean that hospitals are abundant with nurses. Yeah, they're really facing challenges. They're losing nurses to other settings, outpatient settings, especially remote work, case management, things that you know, especially in COVID, you know, when folks had kids at home and, you know, they simply had to make choices about the kind of job that they could be. And also it's important to note, in the US, we had levels of layoffs and furloughs and what the labor markets called discharges. I say it's being fired, you know, positions that went away that we have not recovered from. And that is different from what, you know, we've seen, but those nurses still exist and many of them would like to be working or could be working. But their expectations are to be working in environments where they can have a fulfilling career and not be demoralized and burned out when they leave every day. And so, you know, I don't think in the US we'll ever solve the shortage, but we have to define at any given time what we mean by the shortage and apply the appropriate policies or solutions to that. I work at a nursing school. I'd love for Congress to send us a lot more money, but that's not going to help get nurses at the bedside, because we know that new nurses are actually the ones who are leaving the bedside most quickly. And, you know, from my perspective as an educator, that's a moral issue. I want nurses that are coming out of our program to have good careers in the settings that they want, and many of them want to be in hospitals, but then they just look bedraggled after a few years, and that weighs on me, and I think should weigh on us as a profession.
All right, thank you so much.
I do want to add to that too. Quint Studer and Katie Boston Leary, and I know Jocelyn Insights did a lot of the research, and I saw a little bit of the data. And, you know, I know we had a lot of nurses retire in California, but I teach public policy in the doctorate nursing practice program at UCLA. And in the spring, I was looking to see how many of our nurses were actually in practice. The majority of the nurses that are licensed in California are still in practice to some extent. But they asked a question about retired nurses, would they be willing to come back? And they said yes. And then when they actually sat down, it sounds like they want to come back as a volunteer and sit and talk to patients, not do the work. So the data is looking like a small percentage actually want to come back in and work, whereas the others just want to interact with patients, which is what the volunteers do. So I'm not sure that, you know, if we were to fix all the problems, we'd get all the retired nurses back into the business. And like I said, the data, I think only 2% were willing to come back and do the job that they did before.
Thank you. Thank you, everyone, for your questions. Thank you to our presenters
Linda Cassidy, would you like to share?
Sure. We touched on the first and second bullet points, the one about various types of policies, and then the discussion on do policies and that sort of thing interfere with innovation of care delivery? And we had a clear theme that came through both of those discussions, and it was that direct care nurses, no matter what it is, need to have the majority voice and one of the most influential voices on how care should be delivered and what these policies should state. So yes, it was a great discussion.
Thank you, Dr. Cassidy. Dr. McHugh?
Hi, we ignored the questions sort of, but had a very good discussion. I think one way to kind of capture some of it was talking a little bit about the limits of kind of formal externally applied policy and the need to adapt to your specific context in many of the ways I think that Dr. Blake outlined in her discussion about her particular hospital, but in other settings as well, being thoughtful about, you know, the role of the manager, the role of nurses together in solving and thinking creatively about within the kind of constructs of what we have, what do we need in terms of information to be able to advocate over and above what might be something in policy, in terms of a minimum. And we had a number of folks identify examples in their own institutions, which again, to me was really another way of highlighting how creative we can be as nurses, how impactful our voice can be, but it does take a lot of work, and it's definitely an uphill climb, but we have a lot of intellectual capital amongst ourselves that we can solve some very hard problems, but also recognizing that we need help to do that.
Thank you for sharing. Next, we will go to Dr. Blake.
Well, we started in one area and we kind of ended a little bit different, but we did talk about the unintended consequence of policy driving our practice. And, you know, I did share that I think the reason people are going to our policymakers is because we haven't been able to solve it ourselves, and that we need to have frontline staff with their leaders, with leaders that have the power to make changes as well. But that we really need to have do more work for us to solve the problem, or we will have somebody, you know, who knows nothing about our practice. And I think in Washington they're struggling just to get along. So I'm not sure I want that group to have anything to do with my practice. But we also talked about making sure that the appropriate support staff are there so nurses can work in top of license, and that things that nurses don't need to do. Or somebody brought up that, you know, with the physician burnout issue, is that a lot of things are getting pushed to nursing, even in the documentation area, where we're now doing social determinants of health. And some of those questions could be asked by a social worker, but it's all falling on the nursing assessment database. And so the nurses are even pushed further and further away from the bedside. So, you know, making sure that we get together and we do what needs to be done to develop some standards to our practice, so somebody from the outside doesn't do it to us because we failed to do that.
That is an excellent point. We really need to control the trajectory and the direction of our practice. Next, we will hear from Zena.
Thanks. So we also veered off script a little bit, touched upon acuity, as well as some of the things that we are not talking enough about, such as EHR, data, AI, and the impact on all of that going forward. So.
And just to add to that, we also identified the need to support new to practice nurses and novice nurses, and to engage them in ways that will keep them at the bedside. And just to be creative about how to support them, how to be there for them, how to show up for them so that they enjoy the profession and stay.
Right, help fostering the work environment where it begins in the nursing schools as well, especially at this point.
Exactly. And last we have Cheryl's group. I know Cheryl had to step off, but would someone from her group like to come off mute and share their discussion?
I wasn't in her group, but I do have a comment I'd like to make to follow up on something Zena said, getting people in as they come into nursing school. One thing that I even think might be helpful is to go further back than that. If you start doing some kind of mentoring in the 8th grade classes as they're headed into high school, because if you don't get them early, they're going to go do something else. And we all know that nobody's going to stay with nursing for 40 years any longer. Those few of us dinosaurs that are still out here that have been there for 40 years, we're the last of a dead breed. And because you can't physically, mentally hold up to it any longer. So start them, get them early, get them for 8, 5, 10 years, something like that. And, then they can move on to something else, but be open to having that kind of rapid turnover, at least get them started in the field.
Exactly. We got to draw them in. Once they're in, then how do we keep them? But it's getting them through that door, because they're barely getting through nursing school before realizing the realities of the profession. Brenda, you can come up mute.
Thank you. So I appreciate this work so very much. The only question I have, so I am Director of Nursing for DOC in Vermont, and we are having a challenge with nursing staffing. And I'm wondering, like in the research, was there any, did you take time to look at the nurses that work in corrections? Because it looks like we're kind of forgotten in some ways, but we are struggling.
Yeah, I can comment a little bit on that. My first job was in a men's state prison in Pennsylvania, and I definitely am sympathetic to the very many issues that are in some ways so fundamentally different, but also many are the same, and it's definitely underfunding, understaffing. Obviously, some issues around safety are affecting nurses everywhere, but corrections is a particular place where that is an issue. We have, one of the biggest challenges is to be able to do studies across institutions or correctional settings, especially with increased privatization in corrections. There are some studies kind of in individual settings that tend to be more on the qualitative side, but I think do capture the kind of scope of these issues. I'm not aware of particular policies other than some very basic regulations around, what minimum staff are available, but those are so minimal that I don't think that they apply to what it means to actually provide good care in those settings. But they do vary by state. There is some federal as well, but that's as far as I'm aware, but maybe others have some insight.
Yeah, I talked about the 4 hospitals, but I didn't talk about all all patients that are incarcerated in the LA County system are incarcerated on I have a fellow CNO that's in correctional health. So there's 5 jails. And they're struggling because they are also dealing with the fact that the sorting of patients in the correctional setting is different than the state law. For example, somebody who's going through gender conforming surgery would be sorted differently in the jail than they would be in a hospital. In a hospital, you put them in a room with the same sex that they identify as. In correctional, they're separated. So they're dealing with not only those issues, but they're also dealing with overcrowding. Many of those patients have mental health issues. And they also have
DNT, ambulance
sorry, not sure how to shut that off. But they also have other issues as well. And they've got, TB and COVID, once it gets in the jail system, is a problem. So, I've been talking with my counterpart there on how we can look at some kind of research that we can do together on staffing and burnout and things like that. And I do have a jail facility myself. I have a jail unit, but we staff based on the nursing minimum ratios as well.
Okay, Dan Keller.
Thanks for taking my question. I'm considering coming out of retirement, but would only do so with a good refresher course, because it's quite a few years since I've been at the bedside. So I would need that for confidence and refreshing skills. Searching the internet, I found very little, actually, and none of it is in person. And of course, nursing is a hands-on job. So I would really want it to include, a skills lab, just to refresh those things. Are you aware of any programs like that are out there in the world today? I sure can't find them.
There are hospitals that offer what they call a fellowship program, and it's return to nursing programs. And so I would look at the individual hospitals in your area and see what they offer, because there are places that are offering, for those people that took time off to have kids and now want to come back into the system. They just call it something different than a residency program. But there are some hospitals that have it, but you have to look at each individual. There are some community colleges that offer courses to kind of bring you back up to speed, but I think it's really better to look for a hospital, because there are a handful of hospitals that are doing that now.
Okay. And so a key word to look for is fellowship?
Fellowship or return to nursing, just some kind of key phrase like that.
Okay.
Because there are some that actually offer it, and in their marketing materials, they actually have it spelled out.
Gotcha. Thank you so much. That's very helpful.
Venice.
Hi, thanks for taking my question, and thanks for doing this whole series. It really has been great. Just curious about California has a no mandate to work. I forget what you call the term. You can't mandate a nurse to work in California. Is that right? To work overtime?
No, you shouldn't have mandatory overtime.
Okay.
Some hospitals have different policies, and some of the unions have MOUs, but we can't mandate, but you also can't abandon your patients. So it's it's a catch-22 there. If you walk away from your patient, it could be considered abandonment.
Okay, so I just wondered, with the mandatory minimum nursing ratio, how do you manage when you have call-outs? How is that working for your facility? We struggle with that at my facility. We can flex like in 4-hour increments, but a lot of times when we call nurses back to come in, they simply don't answer the phone. And we realize that that's an accountability issue, but I wondered if there was an on-call, like a standing on-call pool, or do you just do it during the times when the need arises?
Well, we have the ability now with our new system to text out for those that want to work overtime. So that's the first thing that we do. The second thing that we do is we may close beds, although we try not to do that. The third thing that we do is we'll bring the breaker into the staffing, and then we go out of ratio when people go on breaks. Or they bring the chargers into ratio. Or in some facilities in California, the manager has to come in, or they'll pull other people into bedside care that aren't normally bedside care folks. So there's a variety of things people do, because you sometimes can't fix the problem if somebody's in an accident and they don't show up for work, or somebody just doesn't show. You have to do what you do. So they do a lot of floating. They do a lot of trying to balance the workload at the last minute.
Okay, all right, thanks.
If I could just comment, I mean, this is a great kind of question and interaction, but it may be, I don't know who the body is to do it, maybe folks in the ANA or otherwise, but kind of creating some repositories for best practices or potential options and ideas for addressing these real kind of world day-to-day, shift-to-shift issues. And, you know, kind of a clearinghouse, I mean, around some of these things that we can, in many ways, I think, crowdsource the real, you know, vast amount of experience and interest across the profession. Not to give anyone more work, but I was trying to note all the things that Nancy was saying, because it sounds like, you know, a potential solution to something, or and I'm sure there's many more.
And Dr. Delgado just added to the chat, ACN has staffing resources gathered from the community. And she put the link in the chat if anyone's interested. Bridget?
Yes, thank you so much. I just wanted to piggyback on the nurse that talked about correction department. I'm in New York City, and because most of the discussion was on hospital and acuity care, I said I was going to email on the side, because I've been on quite a bit of sessions related to nursing outside of ANA, just others that may offer you know, classes or some knowledge, whether it's free or paid for, and I don't often hear correction being mentioned, and it seems like it's so underserved and so under-reviewed. And even when I'm with my organization, because primarily we have more hospitals, we're the only correctional facility under our hospital corporation, that even that you don't hear some of the things that's being done, whether it's training, whether it's some sort of preparedness, whether it's a new data system, or just the point about patient-nurse ratio in a correctional facility. You know, we deal with general population, we deal with mental health, and also we have huge staffing issues, because it's a setting that not many people, you know, may, you know, want to work in. And it's a wonderful profession to work in, because it is a world within its own, and it gives a snapshot to our communities, and there's so much you can learn. And there's also a public health aspect involved in it. So when you know, your patient/inmate returns to the community, because it's not a life sentence for the majority of them, you want them to be able to link to care and just also feel comfortable with what they've learned or gathered, or the care that they was given. So I would like to see more emphasis in that when I'm involved in any training on any level, and especially when it's state, and you know, that's brought into the spectrum. Thank you.
I'll just add one comment on that I didn't mention previously. I am now recollecting, I think some state prison societies, kind of advocacy organizations, I think they have in some states, I think Pennsylvania is the one I'm thinking of, it has come up, nurse staffing issues have come up as something that is a concern. I don't know whether they've made any progress on that front. I am somewhat skeptical that they have, but there may be some more out there that that other organizations kind of outside of nursing have been thinking about in terms of thinking about staffing issues
thank you to all of our presenters today, Dr. Blake, Dr. McHugh, Dr. Perkins, as well as the presenters that we had over the course of the 5 sessions. We have 2 of our presenters with us today, Dr. Cassidy and Dr. Delgado, who also facilitated. So I just want to extend that thank you to them for helping make the series what it was, as well as everyone who joined us today and throughout the 5 sessions.